170 years ago, Karl Rokitansky looked through a microscope and described endometriosis for the very first time.
Right, way back in the 19th century.
Yeah. And you would think that after a century and a half of, technological advancement, modern medicine would have the absolute basics of this disease figured out.
You really would. I mean, it seems like plenty of time.
But if you walk into a medical conference today, doctors will still intensely debate one fundamental ground level question.
Yeah, it's wild.
Is this disease actually getting worse inside the patient over time, or is it just sitting there getting older?
And the longevity of that debate is what's truly staggering,
Oh, absolutely.
You have generations of surgeons, decades of clinical trials, and just an ocean of patient data. Yet the medical community has been circling this exact question without reaching a definitive consensus.
Which is crazy to me.
It is. The dividing line is sharp. One camp insists the disease is naturally progressive and aggressive, while the other looks at their clinical data and argues it frequently stays stable or even spontaneously regresses.
Which is exactly why you and I are here today.
Let's get into it.
Welcome to the Deep Dive, everyone. Our mission today is to completely decode the natural history of endometriotic lesions.
We are getting to the bottom of this.
We are going to figure out why the medical community has been so profoundly confused for decades.
Right.
And more importantly, we are going to look under the hood at what is actually happening at a microscopic molecular level inside the body.
Because that's where the real story is.
Exactly. And we aren't just theorizing here for you today. Today's insights come from a truly groundbreaking feature review recently published in the prestigious journal Trends in Molecular Medicine.
It's an incredible piece of work.
It really is. The paper is authored by Sunway Guo, Michel Canis, and Paolo P. Vercellini.
And what Guo, Canis, and Vercellini have done in this paper is, well, they've essentially provided a unified theoretical framework that finally makes sense of all the chaos.
Right.
They've taken the contradictory patient outcomes, the conflicting animal models, and the decades of arguing, and distilled it into a single biological narrative.
A narrative that explains why both sides of the historical debate actually thought they were right.
Exactly. They solved the puzzle.
And I've got our resident expert right here to be our ultimate guide through this cellular maze, helping translate the deep molecular biology into clear insights for you, the listener.
I am ready.
So, okay, let's unpack this. I want to start with the sheer scale of the confusion because in the notes, it mentions that since 1971, doctors have proposed over 20 different classification systems for endometriosis.
20. Just think about that.
Right. The most famous one being the Revised American Society for Reproductive Medicine staging system, the RASRM.
Yeah, that's the standard one most patients hear about.
But the paper argues these staging systems are basically useless for predicting the patient's future.
Completely useless for prognosis.
So why are we using tools that don't actually tell us if the disease is progressing?
Well, to understand why the tools fail, we have to look at what they're actually measuring.
Okay.
The RASRM, which gives patients that classic stage 1 through stage 4 diagnosis after a laparoscopy, it's essentially a point system based on visual inspection.
So the surgeon is just looking around?
Exactly. The surgeon looks at the pelvis and assigns points based on the number of lesions, how deep they appear to invade the tissue, and the presence of adhesions or cysts.
So it's essentially an inventory, like a physical head count of the damage in the pelvic cavity.
That is a highly accurate way to describe it. It's an inventory of extensiveness.
Right.
But the critical flaw highlighted by the authors is that this physical inventory does not correlate with symptom severity, and it lacks true prognostic value. You routinely see patients with stage 4 endometriosis, widespread lesions and frozen pelvises, who report minimal daily pain.
Wait, really? Minimal pain with stage 4?
Yes, it happens frequently.
Yeah.
And conversely, you have patients with a single tiny stage 1 lesion who are entirely debilitated by their symptoms.
See, that is where I get stuck. With almost any other disease, if an oncologist tells you that you have stage 4 cancer, that implies a very specific, severe clinical reality.
Exactly. It dictates a specific trajectory.
But here, the staging doesn't predict the pain, and it doesn't predict the behavior of the disease moving forward.
The confusion stems from historically conflating two entirely different types of progression.
Okay, lay it out for us.
When a patient or a doctor asks, "Is endometriosis progressive?" they're usually asking two questions mashed into one.
Two questions.
Yeah. Are we talking about the progression of the patient's symptoms or the biological progression of the lesions themselves?
Let's separate those out because the paper makes a huge point of drawing a line in the sand between them.
So, symptoms involve massive secondary changes in the body. When a patient lives with chronic pain, their nervous system physically adapts.
It rewires itself.
Right. They could develop central nervous system sensitization. This means neuroplastic changes occur in the brain and spinal cord, making the body hyperreactive to pain signals.
Oh man, so the baseline for what registers as painful drops significantly.
Exactly. That neurological shift is absolutely a progression of the patient's disease state, but it doesn't necessarily tell us what the physical endometriosis lesions are doing in the pelvis.
Got it.
A lesion might be completely static, but the pain is progressing because the nervous system is amplifying the signal.
Okay, that makes total sense. Relying on old staging scores like the ARIA-SRM to measure the biological progression of the disease, it feels like trying to judge the quality, complexity, and age of a novel simply by counting the number of words.
Oh, that's a brilliant way to look at it.
You are measuring how far the ink has spread across the pages, but it tells you absolutely nothing about the actual maturity of the narrative.
Exactly.
Like, a massive 1,000-page book can be simplistic, while a short 3-line poem can be incredibly complex and dense.
I love that analogy. The staging systems measure how far the book extends, not how biologically mature the lesions are.
Right.
And realizing this brings us to another massive pitfall in past research that the authors highlight, the size fallacy.
I read this part of the paper 3 times because it completely upends how we usually think about tumors or growths.
It really does.
The historical assumption has been that if an ultrasound shows a lesion hasn't grown in millimeters over a 2-year period, the disease is stable.
Right. That's the standard clinical thought process.
Well, the authors argue that using size as a measuring stick for progression is fundamentally flawed.
We have been conditioned by oncology to think that bad things in the body always grow infinitely larger.
Like a tumor just expanding.
Right. A tumor gets bigger and bigger. But endometriotic lesions are not tumors in that sense. They behave much more like wounds.
Like a cut on your skin.
Yes. And wounds face biological constraints. If you sustain a deep cut on your arm, the wound doesn't just keep expanding outward until it covers your whole body.
That would be terrifying.
It would. No, it reaches a predetermined physical limit based on the initial trauma, and then the biological process shifts inward.
Okay.
It stops growing in circumference and undergoes an intensive remodeling process.
So it scabs, it changes texture, it pulls tight, and eventually forms a dense scar.
Exactly.
The perimeter doesn't move, but the internal structure is completely transforming.
Furthermore, they're constrained by the local microenvironment in the pelvis.
What do you mean by that?
Well, they run into other organs, they exhaust their local blood supply, or they hit physical barriers in the pelvic fascia.
Oh, so they physically run out of room.
Right. So if a researcher or doctor is looking solely at the diameter of a lesion to determine if it's pressing, they're completely missing the microscopic remodeling happening within.
That is wild.
A lesion that hasn't grown a single millimeter in 3 years might be aggressively progressing in its biological severity.
Which is a crucial takeaway for you listening right now. If your physician is only tracking the physical dimensions of a lesion on an MRI to tell you if your disease is stable, they might be missing the entire biological reality of your tissue.
They absolutely might be.
They are measuring the dimensions of the book cover, not reading the dense text inside.
To finally read that text, Guo, Canis, and Versellini introduce a paradigm-shifting theoretical framework in this paper.
And this is the core of it all.
It completely reframes how we view the origin and evolution of these lesions.
Yeah.
The acronym they use is ReTIAR.
Right. ReTIAR.
Yes. It stands for Repeated Tissue Injury and Repair.
Let's dive deep into ReTIAR because this is the engine of the whole paper.
It really is the foundational engine.
In the notes, it explains that endometriosis is essentially ectopic endometrium.
Right. Tissue similar to the lining of the uterus but located outside of it.
Like on the bowel or the ovaries. And because it's similar tissue, it's hormonally responsive and undergoes cyclic bleeding every month, just like a normal period.
Exactly.
But I want to understand the biological mechanism of what happens next. Why does a misplaced period trigger such a catastrophic response?
The environment makes all the difference. When the utopic endometrium, the normal lining inside the uterus, bleeds, that blood has a natural exit route through the cervix and vagina.
Right. The body knows what to do with it.
The body expects that process. However, when an ectopic lesion bleeds on the surface of the ovary or deep in the pelvic cavity, There is no exit.
It's just trapped in there.
The blood is trapped. More importantly, we have to look at this through the lens of evolutionary biology.
Oh, evolutionary biology, I like this.
The human body is hardwired to interpret any internal bleeding as a sign of critical vascular damage.
Oh, because historically, if you are bleeding into your pelvic cavity, you've suffered a massive trauma.
Exactly.
An organ has ruptured or you've been attacked. It's a physiological crisis.
It is the ultimate alarm bell. The body doesn't know it's just a few millimeters of misplaced endometrial tissue responding to estrogen.
It just sees blood where blood shouldn't be.
It just detects internal hemorrhage. So this cyclic bleeding triggers an incredibly powerful, evolutionarily conserved wound healing response.
The body calls in the cavalry.
It does. It initiates hemostasis clotting to stop the bleeding. Then it sends in a highly coordinated cascade of immune cells.
What kind of cells are we talking about?
Neutrophils are the first responders, rushing in within hours or days to secure the area.
Like the paramedics.
Right. Following them are the macrophages, which act like the cleanup crew, clearing out cellular debris and broken down red blood cells.
Okay.
Then come the platelets, releasing growth factors to rebuild the tissue. Their singular biological directive is to fix the wound and restore structural integrity to the area.
Wait, I'm stuck on something here.
What is it?
For years, the prevailing theory in a lot of medical literature has been that endometriosis is partly an autoimmune issue, that the immune system is somehow defective or dysfunctional because it fails to clear out these rogue endometrial cells.
Yes, that was the dominant narrative for a very long time.
But if I'm understanding the ReTIAR concept correctly, you're saying the immune system isn't failing at all.
It is arguably overperforming.
Wow.
The ReTIAR framework flips that old theory entirely on its head. The immune system is doing exactly what millions of years of evolution designed it to do.
It's trying to heal the wound.
It is aggressively trying to heal what it perceives as a bleeding wound. The tragedy of endometriosis isn't an immune failure, it's a timing issue.
A timing issue because the menstrual cycle keeps repeating.
Yes. Wound healing is designed to have a beginning, a middle, and an end.
Right.
But just as the macrophages and fibroblasts are finishing their repair work, laying down new tissue to close the wound from last month's bleed, the hormonal cycle hits again. The lesion gets the signal to shed. It bleeds again. The delicate, newly repaired tissue is ripped back open.
So the body is locked in an infinite loop. Endometriotic lesions are fundamentally just unhealed wounds being repeatedly re-injured and re-stitched every 28 days.
It's a relentless cycle.
It's like the myth of Sisyphus pushing the boulder up the mountain, only for it to roll back down. Except here, it's your immune system trying to close a wound that biology forces open every month.
And this chronic, unresolvable state of emergency has severe consequences for the local cellular environment.
I can only imagine. The cells must be freaking out.
They absolutely are. When tissue repair goes wrong, when it is forced into chronic inflammation, the cells themselves begin to change their identities to cope with the unending trauma.
They change their identities, like they mutate.
Not mutate like cancer, but they transform. The authors detail 3 specific, heavy molecular transformations that drive the progression of the disease: EMT, FMT, and SMM.
Okay, let's break down the mechanics of these transformations, because this is where the physical progression actually happens.
Let's do it.
The first one in the paper is EMT, epithelial mesenchymal transition.
Right.
I know that epithelial cells are the standard building blocks of organ linings, but what physically happens to them during EMT?
To visualize EMT, think of normal epithelial cells as a tightly constructed brick wall.
Okay, a brick wall.
They are highly structured, they are completely stationary, and they are rigidly bound to their neighboring cells by specific adhesion molecules.
What kind of molecules?
Most notably, a protein called E-cadherin. This E-cadherin acts like the mortar, maintaining a strong, impermeable barrier.
So the bricks are locked in place.
Exactly. But when these cells are subjected to the chronic inflammatory soup of the ReTIAR process, they undergo a radical transition.
Yeah.
They drop their E-cadherin.
They dissolve the mortar.
They do.
Why would a cell intentionally detach from its neighbors? What's the biological advantage there?
Think about a normal, temporary wound. You need cells to migrate into the gap to close the cut.
Oh, so they need to move.
Right. By transitioning into a mesenchymal cell state, the cell trades its rigid structure for mobility.
That makes sense.
It becomes unstructured, highly mobile, and invasive, It grows cellular protrusions that allow it to literally crawl through the extracellular matrix.
Okay, so in a normal paper cut, the bricks turn into free-roaming contractors, crawl over the gap, and then presumably turn back into bricks once the skin is closed.
That is exactly how it's supposed to work.
But in endometriosis, because the wound never closes, they just stay in this aggressive, mobile, invasive state.
Yes, and that explains how the lesions spread locally.
That is fascinating. What about the second transformation, FMT, fibroblast to myofibroblast transdifferentiation?
That's a mouthful, I know.
It is. Where do these fibroblasts come from, and what triggers them to change?
Fibroblasts are the primary structural cells present in all connective tissue. They are usually quite passive, acting as the quiet maintenance crew that slowly turns over the structural scaffolding of your tissues.
Just doing their routine maintenance.
Exactly. But the chronic injury signals from the ReTIAR process, specifically a signaling molecule called TGF-beta1, base these resting fibroblasts and force them to transdifferentiate into myofibroblasts.
Okay, the prefix myo refers to muscle, so they are taking on muscle-like properties.
They essentially become a hybrid cell.
That a hybrid.
Yeah. They gain the synthetic, heavy-lifting building capacity of a fibroblast, combined with the contractile pulling power of a smooth muscle cell.
Whoa.
These myofibroblasts are hyperactive. They start aggressively synthesizing and dumping vast amounts of extracellular matrix proteins, predominantly dense type I collagen, into the surrounding area.
So they are just flooding the zone with collagen.
They are. And because they have that muscle-like contractile ability, they physically pull on the collagen fibers, tightening the tissue.
So our mobile contractors have recruited a hyperactive crew that is frantically dumping structural cement everywhere and pulling the tissue incredibly taut.
That's a very vivid and very accurate picture.
And the final transformation mentioned is SMM, smooth muscle metaplasia. Now, metaplasia usually means a cell turning into a completely different type of cell where it doesn't belong.
Yes, it is a pathological cellular adaptation.
So what happens here?
In the chaotic environment of an older endometriotic lesion, you start to see non-muscle cells, like those transdifferentiated fibroblasts we just talked about, or even the cells lining the local blood vessels, permanently transforming into smooth, muscle-like cells.
So you just have random muscle tissue forming.
You end up with bundles of smooth muscle tissue in areas of the pelvis where smooth muscle has absolutely no biological business being.
Looking at these three processes together, the cells detaching and invading, the hyperactive dumping of collagen, and the chaotic formation of misplaced muscle tissue, it sounds like absolute physiological panic.
It is a state of chronic cellular panic.
But the paper points to one specific endpoint for all this activity. What is the final biological destination of a lesion undergoing all these changes?
The ultimate endgame of EMT, FMT, and SMM is one undeniable outcome: fibrogenesis.
Fibrogenesis.
The creation of dense, rigid scar tissue.
The authors emphatically argued that the true age of an endometriotic lesion, its actual developmental stage and biological severity, is fundamentally defined by the extent of its fibrosis.
So age equals stiffness.
Exactly. How heavily scarred and mechanically stiff it has become.
Fibrosis is the destination. But this raises a massive contradiction in my mind, and I'm sure listeners dealing with this disease are thinking the exact same thing right now.
What's the contradiction?
If all of this cellular panic, the ReTIAR cycle, the collagen dumping, the scarring, is just the body's desperate attempt to heal a wound and protect itself, why does it result in such excruciating, life-altering pain?
It's a great question.
Like, a scar on my knee doesn't send me to the emergency room, so why does a scar in the pelvis cause such agony? That is the pivotal question. And the answer lies in the concept of the lesional microenvironment.
The microenvironment.
Yes. To understand the pain, we have to stop looking at the lesion in a vacuum and start looking at where it is growing. The authors brilliantly illustrate this by comparing deep infiltrating endometriosis with ovarian endometriomas.
Right, because clinically they behave very differently.
Very differently.
Ovarian endometriomas, the so-called chocolate cysts on the ovaries, are physically distinct from deep endometriosis, which aggressively infiltrates the bowel, the bladder, or the ureters.
And their microenvironments are vastly different. Deep endometriotic lesions are almost invariably located in close proximity to the major nerve plexuses of the pelvic cavity.
Oh, they grow right next to the nerves.
They grow near dense bundles of sensory and autonomic nerves. As the deep lesion undergoes its repeated cycles of injury and repair, it doesn't just scar over quietly. It actively engages in a complex biological crosstalk with those nearby nerve fibers.
The tissue is communicating with the nervous system, How does scar tissue talk to a nerve?
Through a process called neuroangiogenesis.
Okay, break down that word for me.
Well, when a wound tries to heal, it requires blood supply and it requires innervation. The regenerating tissue physically releases chemical signals that attract nerve fibers.
It calls them over.
Yes. So the surrounding sensory nerves literally sprout and infiltrate the endometriotic lesion.
They grow right into it.
They do,
Yeah.
but it is a catastrophic partnership. Once those sensory nerves embed themselves in the lesion, they don't just passively sense pain, they actively release specific neuropeptides into the local environment.
What kind of neuropeptides?
Most notably, substance P and calcitonin gene-related peptide, or CGRP.
Okay, I've heard of substance P in the context of pain signaling, but what are these neuropeptides physically doing to the lesion itself?
They act as a massive biological accelerator pedal for progression.
Really?
Yes, substance P and CGRP directly stimulate the fibroblasts. They supercharge the FMT process we just talked about, forcing the cells to dump even more collagen and pushing the fibrogenesis into overdrive.
Oh my.
This is precisely why deep endometriosis, which grows right on top of these nerve highways, is typically far more fibrotic, densely scarred, and excruciatingly painful than an ovarian cyst, which develops in an environment relatively isolated from major nerve bundles.
That is horrifying.
The nerves intended to help heal the tissue literally end up throwing biochemical gasoline on the fibrotic fire.
So the body sends nerves to monitor the wound, but the chemical exhaust from those nerves just cements the wound even further.
Exactly.
That elegantly explains the severity of deep lesions. But the paper doesn't stop at local nerve interactions. It zooms out to look at the entire patient, outlining two specific vicious cycles that biologically trap the patient and accelerate the disease.
These cycles are crucial to understand.
I want to spend some time on the first one, the stress loop, because when I was reading the notes on this, the mechanics of it absolutely blew my mind.
The stress loop is arguably the most profound insight in the entire paper because it directly bridges the lived psychological experience of the patient with the molecular biology of the cellular lesion. We have to acknowledge the reality of the patient. Living with endometriosis involves chronic, severe pain and frequently the heartbreak of subfertility or infertility.
Yeah.
Both of those clinical realities generate immense psychological, emotional, and physical stress.
And enduring chronic pain isn't just unpleasant, it is a physiological trauma that keeps the nervous system in a constant state of high alert.
Exactly. And when the brain perceives this chronic stress, it activates the body's primary systemic stress response networks.
Which are?
The HPA axis, the hypothalamic pituitary adrenal axis, and the SAM axis, the sympathetic adrenal medullary axis.
Okay, a lot of acronyms, but basically the stress highways.
Right. The activation of these axes floods the bloodstream with stress chemicals, specifically catecholamines like epinephrine and norepinephrine.
The classic fight-or-flight hormones. Adrenaline.
Yes.
We're used to thinking of adrenaline as the thing that makes our heart race when we're scared. But how does adrenaline in the bloodstream interact with a piece of scar tissue in the pelvis?
Here is the devastating biological twist that researchers have uncovered. Endometriotic lesions are not just passive lumps of tissue.
Okay.
They actively express a specific receptor on their cell surfaces called the adrenergic receptor beta-2, or ADRB2.
Wait, so the lesions really have built-in docking stations specifically designed to receive stress hormones?
They do.
That is insane.
When the patient is in severe pain, their stress levels spike, and the adrenal glands pump out catecholamines. Those catecholamines circulate through the blood and physically bind to the ADRB2 receptors on the endometriosis lesions.
And what happens when they bind?
When those receptors are tripped, it initiates an intracellular signaling cascade that biologically commands the lesion to accelerate.
It tells it to grow.
It increases the rate of EMT, it pushes more fibroblasts to become myofibroblasts, it drives fibrogenesis.
That is a staggering, tragic irony.
It's awful.
The physical pain of the disease causes the patient immense psychological stress. And that very stress response biologically feeds the disease, commanding the lesions to grow denser, more scarred, and capable of causing even more pain.
It is the definition of a vicious cycle.
The disease effectively uses the patient's own suffering as the molecular fuel to accelerate itself.
The psychological state dictates the biological progression, which in turn worsens the psychological state.
It's a closed loop of misery.
But the authors identify a second parallel trap called the stiffness loop, and this one relies entirely on a field of science called mechanobiology.
Mechanobiology, the biology of physical mechanics and forces.
Right.
I'm imagining cells getting squished or stretched. How does mechanical force drive progression?
As the ReTIAR process drags on month after month, and the hyperactive myofibroblasts continue dumping dense collagen into the space, the physical nature of the tissue fundamentally changes.
It gets harder.
Yes. It loses its elasticity. It becomes rigid and mechanically stiff. Now, we often think of cells as just floating in a biochemical soup, only responding to hormones or drugs.
Yeah, that's how I usually picture it.
But cells are profoundly tactile. They continuously probe and feel their physical environment through receptor proteins called integrins.
Wait, they can actually sense the physical tension of the matrix they are attached to.
Yes, they physically pull against the extracellular matrix, and as the lesion becomes stiffer, the cells feel that resistance.
Wow.
This mechanical stiffness acts as its own signaling mechanism. When a myofibroblast feels high tension in its environment, that physical force is translated inside the cell into a biochemical signal that says, we need more structure here.
Are you kidding me?
The stiffness itself tricks the cells into dumping even more collagen.
Wait, so the presence of scar tissue creates a physical environment that demands the creation of more scar tissue.
Exactly.
It's a self-perpetuating cycle of rigidity.
Precisely. It creates a localized feedback loop that is completely independent of the rest of the body. In fact, the authors note that once an endometriotic lesion reaches a certain critical threshold of mechanical stiffness, it may not even need the monthly menstrual bleeding to continue progressing.
It just runs on its own momentum.
The sheer physical tension of the existing scar tissue is enough to perpetually drive further fibrogenesis. The lesion becomes biologically autonomous.
Okay, looking at the ReTIAR engine, the nerves throwing gasoline on the fire, the stress hormones feeding the receptors, and the stiffness creating more stiffness, this paints an incredibly bleak picture.
It is a formidable disease process.
It sounds like an unstoppable biological machine. But the paper doesn't leave us without hope.
Not at all.
If we understand exactly how this machine works, we should be able to identify where to throw a wrench into the gears. Let's pivot to the mitigating factors. How do we wake these vicious cycles?
The paper outlines several highly effective, scientifically validated mitigating factors that can slow or even halt this progression.
Okay, what's the first one?
The most direct intervention, based strictly on the ReTIAR framework, is the medical suppression of menstruation.
Because that stops the bleeding.
Exactly. If the cyclic bleeding is the primary mechanical injury driving the entire cascade, then inducing amenorrhea, stopping the periods altogether through continuous hormonal contraceptives, progestins, or naturally through menopause, removes the foundational trigger.
You stop the monthly injury.
You stop ripping the wound open every 28 days, giving the tissue a fighting chance to finally resolve the inflammation.
But what about mitigating factors outside of hormonal drugs? The paper mentions lifestyle factors.
The authors heavily emphasize the role of an enriched environment, drawing on fascinating data from animal models.
An enriched environment, what does that mean for an animal?
In these studies, an enriched environment essentially means housing the animals in larger spaces with low stress, high cognitive engagement, and positive social interactions.
Basically the opposite of a high-stress, isolated environment.
Right.
And how does that translate biologically to the lesions?
By lowering the baseline stress of the animal, you dramatically reduce the activation of the HPA and SAM axes.
Oh, the stress loop.
You cut off the supply of catecholamine circulating in the blood, which stars those ADRB2 receptors on the lesions.
So you starve the tumor of the stress hormones.
The stress loop is broken, and researchers observed a measurable deceleration in the fibrotic progression of the disease.
That is incredible.
Furthermore, interventions like caloric restriction and certain anti-inflammatory dietary choices showed associated deceleration, likely by reducing systemic inflammation that feeds the ReTIAR process.
That brings me to the most surprising mitigating factor in the entire paper.
I know exactly which one you mean.
The vagus nerve. I know the vagus nerve is the superhighway of the parasympathetic nervous system, the rest and digest counterpart to the fight-or-flight response.
Right.
But what does the vagus nerve have to do with endometriosis?
Research indicates that vagal tone, the baseline activity of the vagus nerve, is frequently depressed in women suffering from endometriosis.
So their rest and digest system is underactive.
Yes. Their nervous systems are biased toward the sympathetic fight-or-flight state. But researchers discovered that if you actively stimulate the vagus nerve, for instance, through non-invasive auricular vagus nerve stimulation, which targets a branch of the nerve in the ear, it actually hampers the progression of the lesions in the pelvis.
I really need you to explain the mechanism here, because stimulating a nerve in your ear to slow down the growth of scar tissue in your pelvis sounds like science fiction.
It does sound crazy, but the biology is solid.
How are those two connected?
It works through a powerful, systemic anti-inflammatory mechanism known as the cholinergic anti-inflammatory pathway.
The cholinergic anti-inflammatory pathway.
Okay. When you stimulate the vagus nerve, it triggers the release of acetylcholine. This neurotransmitter binds to a specific receptor on immune cells, particularly macrophages, called the alpha-7 nicotinic acetylcholine receptor.
And what does that receptor do?
When this receptor is activated, it acts like a master kill switch for inflammation.
A master kill switch.
Yes. It profoundly suppresses the release of inflammatory cytokines across the entire body. By globally turning down the inflammatory volume, you directly counteract the chronic inflammation driving the ReTIAR process at the lesion site.
That is incredibly empowering. It takes concepts like stress management, meditation, or nervous system regulation out of the realm of generic feel-good advice and firmly grounds them in hard molecular science.
Absolutely. The mind-body connection here is not abstract or metaphysical. It is governed by specific, measurable receptors and neuropeptides.
I want to push back on something, though, because I can imagine a listener, or perhaps a physician trained decades ago, listening to all this evidence about progression and saying, hold on. If the ReTIAR concept is true, and this disease is inherently driven to progress by the very act of menstruation, why did entire chapters of old medical textbooks claim the exact opposite?
That's a very fair question.
There are dozens of published studies from the 80s and 90s asserting that endometriosis is frequently a stable disease that doesn't progress. How did the medical establishment get it so wrong?
That historical contradiction is exactly why Gual, Canas, and Verzolini dedicated a significant portion of this paper to systematic deconstruction.
They tore those old studies apart.
They played forensic investigators, digging into those old studies to expose the massive methodological flaws that led the medical community astray for a generation.
Okay, let's play detective alongside them. Let's look at the human studies first. What were these researchers actually measuring back then?
The foundational flaw in those older studies lies in their patient selection bias.
Who were they studying?
Back in the 80s and 90s, when researchers performed second-look laparoscopies, operating on a patient, waiting a period of time, and operating again to see what changed, they overwhelmingly recruited infertile women who did not report pelvic pain.
Wait, they were studying asymptomatic women to determine the natural history of a disease famous for causing excruciating pain?
Yes. Because these women were already undergoing surgical workups for infertility, it was convenient to study them.
Oh, wow.
But think back to the mechanics of the stress loop we just discussed.
Oh my God. If the patients don't have chronic pain, they aren't generating that massive, continuous psychological stress response.
Exactly.
Their HPA and SAM axes aren't constantly flooded with catecholamines. They aren't constantly triggering the ADRB2 receptors on their lesions.
Precisely. By selecting asymptomatic patients, these researchers inadvertently stripped away the primary biological impetus for aggressive progression.
They were looking at a completely different biological ecosystem.
They were studying the disease in an artificially calm biological environment. The authors explicitly state that studying only painless infertile women hopelessly biased the results toward finding stable disease.
That is such a massive oversight.
Furthermore, the observation periods in these older studies were remarkably short. They typically waited only 6 to 12 months between the first and second laparoscopy.
6 to 12 months is nothing in the lifespan of a chronic disease that a woman might deal with for 40 years.
Exactly. Over a mere 6 months, a lesion might not show visually obvious macroscopic changes in size or spread on a surgeon's camera, even if it's intensely remodeling at a microscopic level.
Right.
But perhaps the most glaring oversight of all was that these studies almost entirely failed to account for patient age.
Why does the specific age of the patient matter so much when evaluating progression?
It comes back to the size constraint and the end game of fibrogenesis. Imagine a patient who is 42 years old.
Okay.
She has likely had this disease, undiagnosed, since her teens. Her lesions have endured 2 decades of the ReTIAR cycle.
2 decades of repetitive injury.
Yes. They have already reached their biological endpoint. They are deeply mature, densely fibrotic, stiff scars.
They've maxed out their physical dimensions.
Yes. Because of local tissue constraints, an older lesion has generally stopped actively expanding outward.
Right.
It is locked in a state of constant internal cellular remodeling, but it isn't getting visually larger. So if a researcher performs a laparoscopy on this 42-year-old, measures the diameter of a lesion, waits a year, and measures it again, it will look exactly the same size.
And then the researcher writes a paper concluding, look, endometriosis is a stable, non-progressive disease.
When in reality, they are just looking at a fully mature terminal lesion.
That is incredible. Going back to our analogy, it's like a building inspector looking at a fully constructed, impenetrable brick wall and noting that it hasn't gotten any taller or wider in the last year, so they conclude the construction crew must have packed up and gone home.
That's a great way to visualize it.
But if they looked closer, they'd see the crew is still there every single day, meticulously packing more and more high-density cement into the microscopic cracks, making the wall exponentially stronger and harder to tear down.
That is a flawless summary of the oversight. To definitively prove this dynamic, and to bypass the ethical impossibilities of simply leaving human patients untreated for years just to watch their lesions mature, the authors highlight highly controlled animal studies,
Right, the animal models.
specifically baboon and mouse models.
Let's talk about the baboon study, because reading about that was the smoking gun for me. Why baboons?
Baboons are a critical model because, unlike mice or most other mammals, non-human primates experience a natural menstrual cycle virtually identical to humans.
Oh, so they naturally have periods.
They naturally undergo the exact same cyclic ReTIAR process. In a landmark, highly controlled study, researchers deliberately induced endometriosis in baboons.
What?
They then performed serial evaluations of the exact same lesions at 3, 6, 10, and 15 months.
So they basically had a time-lapse camera on the natural evolution of the disease. What did the cellular timeline show?
It showed a perfect, irrefutable chronological progression toward fibrosis. The biochemical markers told the whole story.
What were they looking at?
As the months passed, the researchers measured a steady, progressive decrease in the levels of E-coherin.
Okay, recalling our earlier discussion, E-coherin is the mortar. It's the adhesion protein that keeps the epithelial cells structured and stationary, so the mortar is dissolving over time.
Exactly. The cells were losing their structure. Simultaneously, they tracked the levels of alpha SMA, or alpha-smooth muscle actin.
And what does that indicate?
This is the definitive biochemical marker for myofibroblasts, those hyperactive muscle-like cells responsible for dumping collagen and creating scar tissue.
Okay, so what happened to those levels?
The alpha SMA levels progressively skyrocketed over the 15 months. And when they evaluated the overall tissue density, the extent of physical fibrosis perfectly mirrored this timeline.
Wow.
The longer the lesions were exposed to the cyclic bleeding, the stiffer, denser, and more scarred they became.
So the animal models provide the definitive proof. If you let the disease run its natural course, driven by the engine of menstruation, it undeniably progresses toward dense fibrosis.
The evidence is overwhelming.
The old human studies missed this reality because they were looking at the wrong subgroup of patients for far too short a duration and using a deeply flawed measuring stick of just evaluating the visual circumference.
Exactly. However, this revelation raises an immediate, highly practical question.
What's that?
If visual size and subjective staging scores are useless, and if the density of the fibrosis is the true, accurate measure of disease progression, how do we actually utilize this new paradigm to help human patients in the clinic tomorrow?
Right. We can't just keep doing surgeries to check.
We obviously cannot perform a surgical biopsy on every lesion every 6 months to check its alpha SMA and E-cadherin levels.
Right. If the old tools are broken, we need a new diagnostic tool, a new measuring stick that can accurately read the maturity of the disease without cutting the patient open.
And the paper points to a specific imaging technology as the future.
Elastography.
Yes, elastography.
I'm somewhat familiar with ultrasounds and MRIs, but how does elastography work in this context?
Elastography is an advanced medical imaging technique that can be integrated into either ultrasound or MRI. Instead of just taking a static picture of the anatomy, it actively maps the physical elastic properties of soft tissue.
So it feels the tissue.
It essentially measures how physically stiff or rigid a specific area of tissue is. Historically, it was developed and used extensively in hepatology to non-invasively quantify liver cirrhosis.
And liver cirrhosis is essentially just advanced fibrosis of the liver, so it's a machine literally built to measure scar tissue.
Exactly. And now it is rapidly emerging as the gold standard for the future of endometriosis diagnosis.
That makes total sense.
Because if we accept the ReTIAR framework, that the biological age and clinical severity of an endometriotic lesion is intrinsically defined by how fibrotic it is, then measuring its mechanical stiffness gives the physician a direct, non-invasive window into how far the disease has progressed along that timeline.
You are finally measuring the correct biological variable. You are measuring the maturity of the tissue, not just how much space it takes up. But the paper takes this a step further, arguing that knowing the stiffness of a lesion isn't just an academic exercise, it is critical for determining how to treat the patient. Why does the physical stiffness of a lesion change how a doctor should prescribe medicine?
Because as these lesions become highly fibrotic and mechanically stiff, their fundamental cellular biology undergoes a drastic terminal shift.
They stop acting like normal tissue.
They stop behaving like normal tissue, and they stop responding to normal signals. The authors detail 3 critical biological changes that occur in an advanced, stiff lesion.
Walk us through them.
First, they experience a massive drop in prostaglandin E2, or PGE2, signaling.
What does PGE2 do normally?
PGE2 is a potent inflammatory mediator that drives the early, active, growing stages of the disease. But as the lesion matures into a dense scar, this specific signaling pathway essentially burns out and drops off.
So anti-inflammatory drugs that target early inflammatory pathways might be totally useless on an older lesion.
Exactly. What's the second change? This is the most crucial point for clinical treatment. Older, fibrotic lesions have drastically diminished levels of estrogen and progesterone receptors.
Wait, they actually lose their hormone receptors? How does that happen?
It loops back to mechanobiology. The physical stiffness of the surrounding collagen matrix is sensed by the cells, and this mechanical tension actually alters their gene expression, causing them to downregulate or reduce the manufacturing of these hormonal receptors.
That is wild. And the third change?
The third major change is vascularity. As the myofibroblasts pack more and more dense type I collagen into the space, the tissue becomes so dense that it physically chokes off its own blood supply. The microvessels are crushed.
Okay, let's synthesize this. An older, highly fibrotic lesion, which we can now identify via elastography, has very little internal blood flow, and the cells within it have shed almost all of their estrogen and progesterone receptors.
Now consider what the absolute standard first-line medical treatments for endometriosis have been for decades.
Systemic hormonal treatments. Birth control pills, progestin-only pills, aromatase inhibitors, or drugs like quinagalide that target specific hormonal pathways.
Exactly, and this biological reality entirely explains why these standard hormonal treatments so frequently and frustratingly fail in patients suffering from advanced, deep, highly fibrotic lesions.
It makes complete sense now.
Imagine a physician prescribes a heavy progestin or an aromatase inhibitor to a patient. If that patient's lesions have already progressed to the end stage of fibrogenesis and have lost their progesterone and estrogen receptors, well, the medication circulating in their body has absolutely nothing to bind to.
There are no docking stations.
The drug is biologically useless against that specific mature lesion.
The biological lock has been completely removed from the door, so it doesn't matter how well designed the pharmaceutical key is, it's not going to open anything.
And it gets worse. Even if a few receptors manage to survive, the drastic drop in vascularity means the systemic drug literally cannot physically penetrate the dense avascular scar tissue to reach the target cells in the first place.
Because the blood vessels are crushed.
The blood flow simply isn't there to deliver the medicine.
It has built an impenetrable biological fortress. The tissue has constructed a wall so incredibly thick and dense that the medicine just bounces off the outside.
That is a perfect description.
This is a massive, potentially life-altering revelation for patients. If you or someone you love is navigating this disease, and you are sitting in a doctor's office trying to decide between enduring another 6-month trial of a new hormonal medication with terrible side effects, or opting for a major surgical excision, understanding this mechanism is the missing piece of the puzzle.
It changes everything about the decision-making process.
Advocating for advanced imaging that measures stiffness, like an elastography ultrasound, could be the absolute key to choosing the correct path. If your scan shows that your lesions are highly fibrotic fortresses, medical management might be a complete dead end, and surgery might be the only physical way to remove the source of the pain.
It completely reframes the concept of personalized medicine for endometriosis. It allows physicians to finally tailor their treatment strategy to the specific biological developmental stage of the individual lesion, rather than the archaic approach of just throwing systemic hormones at every single patient and hoping for the best.
Okay, we have covered an incredible amount of dense molecular ground today. Let's do a quick, energetic recap to synthesize everything we've learned on this deep dive.
Sounds good.
Number 1, we definitively answered the 170-year-old debate. Endometriosis is a progressive disease.
Emphatically, yes.
It is driven by the ReTIAR process, repeated tissue injury and repair. Every single menstrual cycle creates an internal bleeding wound that the body desperately tries to fix, eventually transforming normal cells into aggressive, mobile contractors and hyperactive muscle hybrids that construct a dense, stiff, fibrotic scar.
Number 2, we learned that this disease progression does not happen in a vacuum. It is aggressively accelerated by the patient's own stress response, flooding the lesions with adrenaline, and by sensory nerves physically invading the tissue and dumping inflammatory neuropeptides.
Right.
But crucially, it can be mitigated. Suppressing menstruation stops the core injury cycle, while interventions like an enriched environment and targeted vagus nerve stimulation can fundamentally alter the nervous system to biologically decelerate the scarring process.
And number 3. We discover that the medical community has been hopelessly confused for decades because they were looking at the wrong patients and using a broken measuring stick.
Flawed tools lead to flawed conclusions.
Judging the progression of an old wound by measuring its visual size is a fallacy. The future of precise diagnosis and targeted treatment relies entirely on measuring stiffness, using tools like elastography. Because once a lesion becomes a highly fibrotic, avascular scar, it loses its hormone receptors and its blood supply, rendering standard hormonal medications completely ineffective.
The ReTIAR paradigm is a monumental step forward, finally aligning centuries of disparate clinical observations with hard molecular reality.
It really is.
But, as with all truly great scientific leaps, answering one massive question inevitably spawns several profound new ones. Based on the author's conclusions, I want to leave you with a final, lingering thought to mull over.
Let's hear it.
We have firmly established that late-stage, highly fibrotic endometriotic lesions essentially choke off their own blood supply and shed their cellular receptors, creating an impenetrable biological fortress.
Right. The oral or injected medications physically cannot get inside, and even if they somehow breach the wall, there are no receptors left to bind to.
Exactly. So acknowledging this harsh anatomical reality, does this imply that the entire future of non-hormonal systemic drug development for advanced endometriosis is fundamentally doomed to fail?
Oh, wow.
If the target lesion is essentially a block of vascular scar tissue, it doesn't matter how biochemically brilliant a new pill is if the molecules physically cannot reach the target cells.
They literally can't get there.
Are pharmaceutical companies chasing a ghost by looking for better systemic drugs? Or will the next great revolutionary leap in endometriosis research not be a new drug at all, but rather the invention of entirely new, highly localized delivery systems?
Like what?
Perhaps utilizing nanotechnology or targeted mechanotherapeutics designed to physically dismantle collagen just to breach the scar tissue walls.
Wow. That right there is the absolute frontier of medical science. Well, until the biomedical engineers manage to invent tiny microscopic battering rams to break down those biological fortresses inside the pelvis, your best, most scientifically validated defense is to cultivate an enriched environment and aggressively keep your systemic stress levels down.
It's the best tool we have right now.
So take a deep, slow breath. Maybe see about stimulating that vagus nerve in your ear, and go treat yourself to something deeply relaxing. You have officially earned your honorary doctorate in mechanobiology and tissue dynamics today. Thank you for joining us, and we'll see you on the next deep dive.